Hello, everyone. My name is Suresh Ramalingam. I'm a thoracic oncologist at Emory University's Winship Cancer Institute. We hope that you will find the discussion today about the impact of COVID-19 on management of patients, specifically with lung cancer, useful in your daily practices. At this time, I would like to introduce my esteemed faculty panel who will be participating in the discussion with us. Dr. Leora Horn is the Ingram Associate Professor for Cancer Research, Associate Professor of Medicine, and Assistant Director for Educator Development Program and Clinical Director of the Thoracic Oncology Program at Vanderbilt Ingram Cancer Center. Welcome, Dr. Horn. Then we're also joined. Thank you. We're also joined by Dr. Jacob Sands, who is a thoracic medical oncologist at Dana-Farber Cancer Institute and an instructor of medicine at the Harvard Medical School. Welcome, Jacob. And Dr. Charu Aggarwal, who is Leslie Heisler Assistant Professor for Lung Cancer Excellence and Medical Oncologist at the University of Pennsylvania, Penn Medicine. Welcome, Dr. Aggarwal. Next slide, please. I'll start off with our disclosures. These are available to you in your programs. Next slide, please. And next slide. So let's get started. The next slide, please. It's now almost 3 months into the COVID pandemic. When we started off 3 months ago, the approach was shut everything down, stop doing what it is that you're doing. Let's take care of it as the situation improves. Here we are. I want to go around our faculty panel to see how their current situation is at their respective institutions and their geographic area with regards to the pandemic, and what sort of a mode are their institutions in? Are they still ramping down? Are they ramping up? If they're ramping up, at what part of ramp up are they at? So we'll start with Leora.
Yeah, so I'm in Nashville in Tennessee, and so we sort of paused for a little bit, but I don't know that we ever completely ramped down like I hear what other colleagues did around the country. We offered patients telehealth, but many patients wanted to come in and be seen. And for most of our patients, particularly those on therapy, visits continued as normal. I would say for the last month, it's been ramping up and almost back to normal. What we have noticed is we've had fewer new patients. Our thoracic surgeons have only started operating again in the last few weeks. The pulmonologists are only doing bronchoscopies again in the last few weeks. But it's a new normal. Everyone wears a mask in the medical center. Everyone who comes into the medical center has to have their temperature taken. Patients now are allowed one visitor. Before, the no visitors were allowed into the medical center or cancer center with the patients. Visitors can go up to the infusion room. So we're back up to almost normal, but it's definitely a new normal.
Thank you. Jacob, how is the situation in Farber?
Yeah, Boston now has far fewer new cases each day, so the numbers have really come down. We went through a period where we didn't allow any visitors in, with rare exceptions. Now we're on the verge of allowing one visitor in with patients. We've done a lot of remote visits on Zoom. I've learned a little bit about some of the other technologies. Some are easier for some patients than others, so I've learned how best to try and connect with people. But we are kind of slowly opening things up. Our clinical trials have been open the whole time, although we really went through a time where we couldn't do any biopsies that were just for research, and that is starting to open up a little bit more now. We can get some biopsies. The labs are now starting to slowly have a plan for slowly opening, but we really went through a period of quite a clamp down that we're now coming out of as the new cases each day in Boston have dropped significantly.
Excellent. And Charu, what's the situation in Philadelphia?
Yeah, so as we spoke around last time, we hit our peak somewhere in mid to late April, and into our peak, we were early adopters of telemedicine, and we switched to almost a completely virtual clinic pretty early on, with on-site MD presence within each disease site, maybe one MD a week. We are now past our peak, and the cases are declining swiftly, including the number of patients that are admitted in the hospital. We are re-entering our clinics as we speak. We are doing this in quite a phased fashion. We are probably going to be at 40% or 50% of our capacity for the next couple of months, and the goal is to get to about 70 to 80% of our capacity by August. So as you can imagine, our clinics are looking like a very good mix of tele visits and in-person visits. So every week I sit down and look at my scheduled patients and see who really needs to be seen in person, who can still be a televisit, and there's a lot of careful planning that's ongoing on a regular basis. I think the institution has been extremely accommodating because, as you know, most of the physicians here don't have significant childcare options. So I think working from home has been, allowed, and there's a lot of flexibility, which has been great.
Excellent. As for our own institution, it's not very different from what we've heard from the three of you. We are in what we are referring to as the phase 1 of ramp up, which started about a couple of weeks ago, and that was based on the observation that statewide we were seeing a substantial reduction in the number of cases with COVID. Throughout our enterprise, hospitalizations due to COVID were almost down 50 to 60% from its peak. So the institution has slowly started the ramp-up process. We are using the telehealth platform to see as many patients by that platform without having them come into the hospital or to the clinics. But a lot of patients are getting infusions, are due for scans, are still having to come in and meet with their teams. From a clinical outpatient standpoint, we're up to 80 to 90% of where we were in the pre-COVID era. What has been incredible for me to watch is how everybody across the system have come together to work as one team to make sure that we put the patient's interest, safety of the patients, and safety of our staff among the top priorities. And this has meant that everybody starting from our EVP of Health Sciences to the CEOs of the hospitals, the leaders of various service lines, physicians, the nurses, the nurse practitioners, and all staff communicating regularly, daily notifications of what's happening, changes being updated through the electronic medical record system and every other forum that's available, definitely email. So this has truly been remarkable to watch everyone step in at a time of crisis. Now, we have learned a lot in the past 3 months about COVID. There have been a number of publications and even some retractions in Lancet and New England Journal recently. Leora, you presented an important update about COVID in thoracic cancer patients at ASCO 2020. And I was hoping you could walk us through some of the top-line findings from your work and what it means to our oncology workforce looking forwards.
Sure. So I presented the data on TerraVault, which is a global consortium some of you guys are participating in, that's looking at specifically patients with thoracic cancers who contract COVID or get SARS-CoV-2 and develop COVID. And we know that the thoracic patients are a more vulnerable patient population. And at ASCO, we had CCC19 and TerraVault. And in TerraVault, we found that the mortality rate for thoracic cancer patients was higher than what we had anticipated. It was actually 35%, which is almost double to what they saw in CCC19, which looked across different tumor types. What we also found was over 75% of patients with thoracic cancers who develop COVID have to be admitted to the hospital, but only 8% of those patients will ultimately be admitted to the ICU, which is almost half the number than what we see with other tumor types from CCC19. We were also looking at sort of what were the risk factors for admission to hospital, as well as what were the risk factors for death. And we found that in terms of risk factors for death, it was patients who are on prednisone more than 10 milligram equivalent at the time of COVID-19 diagnosis, patients who are on anticoagulation, which has come up as a topic quite often because we know that anticoagulation is often being used for patients with a diagnosis of COVID-19, But these patients, we believe, were in a hypercoagulable state before they even got their COVID-19, and that sort of may have tipped them over the edge. And we are looking into the cause of death of those patients. Patients who had a poorer performance status, so patients who had some limitations in their daily activity, and then patients who had comorbidities such as hypertension, diabetes, COPD, as well as patients who had had chemotherapy either alone or with immunotherapy in combination. You know, I think an important point, because I've had some people contact me and say, well, hey, should we stop chemo and just give immunotherapy for patients who are on chemo immunotherapy combinations? What do we do for adjuvant therapy? And I think the important message is don't delay care, don't stop care, don't start giving your patients substandard care. But we need to figure out a way to minimize our patients' interaction with the healthcare system, because we know that some of these patients actually may have contracted their COVID through interactions within the healthcare environment. And so telemedicine is a great option for some of those 1-week visits rather than bringing patients in for a toxicity check when they first start chemotherapy. I'm curious to see what other people say, because we're starting to draw back on telemedicine, because although it's very patient-centric, we're starting to hear that insurance companies are over the pandemic and they are going to stop reimbursing for telemedicine. And so then how do we offer our patients some of this care? You know, I think we still need to offer our patients the best care possible. We just need to be careful and remind them that even though the cities are opening up and the countries are opening up, they should still isolate themselves. They should still minimize their interaction with others to decrease their risk of contracting the virus.
It's very helpful. Thank you, Leora. What is your best estimate based on literature and your own work is the mortality for lung cancer patients who develop COVID infection?
So for all-comer, this included lung cancer, thymoma patients, patients with carcinoid and mesothelioma, but non-small cell lung cancer was 75% of the patient population. And so we found that 1 in 3 patients who got COVID died, who had lung cancer. From CCC19, the mortality rate was around 18-19%. Of that, they only had about 100 lung cancer patients. They did mention that lung cancer patients had a higher risk of mortality than the other patients that were included in their database. So the risk is high and real. What we also didn't find in our data, CCC19 mentioned the treatment with hydroxychloroquine and azithromycin were associated with increased risk of mortality. We recently had that withdrawal of the paper that you mentioned. We didn't find that any one specific therapy, hydroxychloroquine, any antibiotics, even high-dose steroids at the time of COVID-19 were associated with increased risk of mortality. The numbers are small. At the time of the data cutoff, we had 400 patients. We're at just over 650 patients now in our registry. We're hoping to create sort of a profile of what's your typical at-risk patient, so people can think about these patients when they come into clinic and how they're going to manage them and handle them. But in the first 200 patients that was presented and will soon be published, and the updated analysis, the things that stood out were chemotherapy administration and mortality, as well as some of those other things I mentioned.
Still quite a high number of patients with lung cancer seem to succumb to COVID if they acquire that infection. Clearly a matter of big concern for all of us. Charu, how much of that factors into your treatment decisions as you evaluate patients? The fact that chemo within 14 days seems to be a risk factor, pre-existing use of steroids. Do you factor those things in as you recommend treatment for, let's say, metastatic non-small cell lung cancer?
Yeah, I think all of us are humbled by the data presented by Dr. Horn and Dr. Garasino earlier at AACR, as well as some of the other data that's coming out. And, you know, you mentioned chemotherapy use, but one of the other data points that has struck out at me is, you know, poor performance status being a strong indicator for COVID-19 related mortality. I think that has led me to have more risk-benefit ratio conversations with my patients, especially those have altered performance status or poor performance status, and we are having a conversation about 3rd or 4th line chemotherapy during the pandemic. I think this data has been able to guide us to clearly have some of those conversations. If I have a patient with, you know, very good performance status and they're going in to begin their first-line chemo immunotherapy, I'm strongly considering using growth factor support to be able to minimize the risk of prolonged myelosuppression, or at least minimize the myelosuppression. We are not using it in every case or every patient, but certainly a consideration to be able to provide the best care that we can and not provide substandard care, as Leora pointed out. So I think that those conversations are definitely happening, and I'm factoring those in, as well as really thinking about ways to minimize exposure to the hospital, to the cancer center. So instead of using sometimes weekly chemotherapy regimens, we are using every 3-week regimens. And in the maintenance setting, certainly thinking about going to the Q6-week dosing for immunotherapy, at least.
Yeah, those are some good strategies for our audience to keep in mind. One issue, Jacob, I want to get your thoughts on is about testing for COVID. Is it widely available in your area? And B, is that something you routinely use before you make treatment decisions, or are there any specific algorithms you use to decide who should get tested before they start certain treatments for lung cancer?
We have not been widely testing before treatment, and I know that is happening at other institutions. We've been testing people when they have symptoms or any kind of suspicion, then they get tested, but not widely people who are getting systemic therapy. I believe from other, I believe you guys are doing that, but that has not been a part of our workflow. And I'll say, I think this is a different discussion for me now than a month ago, with the numbers dropping, and I think just to make a point that across the country, the people watching this, that the different points that they're on locally are going to impact their decision making locally as well. So just the different regimens that they're choosing, I think I'd be a little more aggressive about some of the regimens I'm choosing now, as opposed to my concern a month or two ago, when we didn't know where our peak was really going to be or how full the hospital would be. Where my bigger concern with patients ending up in the hospital at all just because of increasing numbers of COVID in the hospital. So now I think the situation is we have a little more room in Boston. Things are a little better with the decreasing numbers, but widespread testing has not been a part of our workflow.
Okay. Leora, are you testing patients before you give them chemotherapy at least?
We are, yeah. So anybody who is getting chemotherapy, I'm not testing them if they get immunotherapy. That's sort of a treatment-specific decision per disease team. But with the data from Memorial Sloan Kettering, as well as the data that we have from TerraVault, immunotherapy does not seem to put patients at risk. But any patient starting on chemotherapy is getting tested. We're also, any patient getting any procedure, bronchoscopy, GI procedure, those patients also getting tested. The testing comes back within 24 hours. There is the point that, patients have raised, well, I was negative yesterday. What about before my next cycle of chemo? We are not repeatedly testing, but we do that initial.
So obviously an important issue. Our hematology colleagues who use more myelosuppressive regimens, in my conversations with them, I learned that they are doing a lot of routine testing before they move forward with some of these induction consolidation kind of treatments for hematological malignancies. But if you take a step back, on this slide, you see some of the points the NCI put out as the impacts of COVID-19 on cancer care and research. And we could easily think of each one of these bullet points as it applies to our lung cancer patient population and talk through that. The first issue is diagnosis and staging. What is the impact of COVID? How delayed our diagnosis? Are we seeing more advanced stage patients? Perhaps it's a bit too early for that, but certainly when we went through the peak of the COVID-19 pandemic in our respective cities, we saw a significant drop in hospitalizations, emergency room visits, patients calling in for new patient visits. And we know that the incidence of lung cancer has not changed. So these patients are going to end up being diagnosed ultimately. But Jacob, talk about what's the impact of COVID on lung cancer screening and diagnosis.
Yeah, so lung screening, we know from studies this is something that about 8 million people in the U.S. qualify for. An estimate by the American Lung Association is that if everyone who qualified had lung screening, it would prevent 48,000 lung cancer deaths per year, which, to put that in perspective, is more than the number of people that die from breast cancer each year, which we want to cure all of them, but just for perspective's sake, this is a lot of people. Lung screening up to this point has a lot of hospitals are figuring out how to put together programs or how to increase their programs. So I think even before the pandemic, we were way under screening, but certainly this has put lung screening on hold in many cities. And we saw the publication that really showed about a 90% drop in all screening, in breast cancer screening, cervical screening, colon screening. So this has affected all screening. Lung cancer was already kind of starting low, but certainly has been put on hold. I think the challenge is that, as you point out, lung cancers don't stop. They still end up developing, and we still need to catch them earlier. And the challenge is, how do we now get all of those people who maybe have been delayed a few months for their lung screening in to make sure we're still catching everybody? We don't want people to skip a year. We saw from the Nelson screening data out of Europe that when there was a 2.5-year time frame between scans versus a 1-year time frame, there were far more later stages diagnosed at that time point. So even skipping a year, we will see many more later stages within that screening program. So it's important to get those people in. So then it's a matter of figuring out how do we do the workflow so that we're making sure we're really protecting every single person who comes in. And there's a lot of discussion on that now. As the numbers drop down in cities, then that becomes easier to open up. But I think for the time being, this is a workflow that's going to have to be figured out until there's really COVID vaccination and full control.
Yeah, that's certainly a double whammy for lung cancer. We're talking about early diagnosis. Now we're in the opposite end, delayed diagnosis for lung cancer, which is going to make it harder to perhaps make sure the patients have the best shot of achieving long-term survival. Charu, how is early stage lung cancer managed in your program now? Is surgery back? Are the surgeons back in operating these patients, or are you still thinking about delaying surgery and doing something in the intervening period?
Yeah, great question, Ram. We were fortunate to never actually get into a phase of delaying surgery for early stage lung cancer patients. I think we had enough capacity there. Probably was a very short period of time where, we considered maybe taking a hiatus, but our surgeons were able to continue to operate, had enough ventilators and OR capacity at our institution. But, we did see that there were certain institutions, especially in New York, where these early stage lung cancer patients were treated with more radiation therapy techniques, similar to the inoperable lung cancers, even if they were operable. But thankfully, we did not see that. I will say that during the peak of our pandemic, when I did see some post-surgical patients who needed adjuvant therapy, I felt comfortable saying that, let's just wait the full 10 to 12 weeks before we initiate adjuvant chemotherapy, and didn't feel compelled to do that within the window while we were in peak, during the peak of the pandemic. So we definitely had those conversations with our patients.
Yeah, and you talked about radiation as an alternative surgery. Certainly that has come up in our practice as well. If a patient had very early stage lung cancer, should we just do SBRT and not put them through surgery? Our current situation is, thankfully, our surgeons are back now operating, and the delays for surgery have gone down. But there was a time where people were starting to think about using neoadjuvant type of therapies to help fight the disease, as well as buy time to do the surgeries until the COVID situation improves. Leora, how is the situation with surgery and SBRT in your institution?
Yeah, so it's interesting because I feel like our radiation oncologists are always recommending SBRT, and our surgeons are always saying, let's do surgery, and that trial is never going to be completed in the US. So surgery paused a little bit in that the surgeons had to justify an urgent surgery. As Charu mentioned, lung cancer is often considered urgent. So the surgeons, for the most part, were able to continue. Where we did find, and I think we are going to continue to see, is we're not seeing as many patients coming through the screening program. We didn't see it for a couple months. We definitely haven't caught up. And we have a really large catchment area, and we have a lot of patients who wanted to come to Vanderbilt, but wanted to get their wanted Vanderbilt's involvement, but wanted scans closer to home. And that actually also resulted in delays in care, because sometimes it takes a few extra weeks for the scans to make it, for things to make it. But the surgeons are back and functioning, and we will continue to debate the SBRT versus generous wedge or a anatomical resection, as the surgeons say, probably for the next few decades that I'm practicing.
I want to pick up on something Charu mentioned, which is delaying adjuvant chemotherapy at the peak of this crisis. Do you or the rest of the faculty feel like the time has come now to get moving forwards, or are you still holding off on adjuvant therapies if that's something you decided to move forward with? Jacob?
No, I think in Boston the numbers are okay enough that moving forward, I would give people treatment at this point. But certainly during the peak that we had, I would be comfortable putting it off. As Charu points out, really you can give up to 12 weeks. So if it's 4 weeks after surgery, I'm not nearly in the same kind of rush, knowing that there is time. All things being equal, I like getting people treated earlier. I think that's good, and I aim for really around 6 weeks. But if that's in the middle of a peak, that really changes the risk-benefit balance. And the last thing you'd want is someone to show up in the ER with neutropenic fever when the ER is slammed with seeing a bunch of complicated and difficult COVID patients. And thankfully, that's not happening now. So for the time being, I am more comfortable. But if that surge happens again, then it would change the equation again.
Are you using any different type of approaches or different type of chemotherapy agents in this situation? We know that cisplatin-based adjuvant chemotherapy is the evidence-based standard. Are folks comfortable using cisplatin with a second agent in the adjuvant setting like we did during the pre-COVID era? Leora?
For the most part, we've been...
Oh, no, sorry. Go ahead. I would say cisplatin is actually easier than carboplatin, because carboplatin is even more myelosuppressive. So we're sort of taking an approach. What Charu was doing is I'm using more growth factor. So we are doing more GCSF for patients in the adjuvant setting, something even in the metastatic setting that I didn't normally do. But we're also fortunate in Nashville. We never had a peak. We sort of had a steady something. And so we never slowed down with adjuvant therapy for our patients. But we did sort of follow some of the NCCN recommendations of giving growth factor support for patients.
Charu, you were going to say something as well.
I was just going to say we're just staying away from perhaps offering a Taxotere-based regimen for our squames in the adjuvant setting and choosing, gemcitabine instead. We'd always use cisplatin and pemetrexed for our non-squames, but perhaps favoring more of a gemcitabine-based approach.
Great. Now let's shift gears, talk about locally advanced non-small cell lung cancer. What has been the impact of COVID on managing patients with Chemo RT and subsequently giving Durva as consolidation therapy? Jacob, talk about Chemo RT. Has your Chemo RT approach changed because of COVID?
Well, I mean, these are patients that really can't delay. These are people where you have a shot at cure, and so you can't delay. So, in these people, maybe the weekly carbotaxol during the times of surges, that's generally pretty well tolerated, where I don't worry as much about that as opposed to cystotopicide. In normal times, I do give cystotopicide as well. But otherwise, no delays. As far as the durvalumab I haven't yet given people Q4-week dosing. I have heard that mentioned a little bit along with in settings of Pembro, there's now 6-week dosing. But for the Durva, as far as the Pacific regimen, I have been giving every 2 weeks as well. Again, I'm not in a rush to get the Durva going. I know that there's been discussion that in Pacific, that people who got started on Durva earlier ended up doing better. And I think that's also people who did much better through the therapy, that they're able to move on to that earlier. So I'm not in a rush. All things being equal, I don't want long delays in that, but it doesn't have to be 4 weeks after necessarily. So if it's in the middle of time, I might push that back a couple weeks if there's a surge of time. But right now, the way things are in Boston, I don't think I would hold up anything.
So interesting, you mentioned delaying Durva, and at least in the Pacific trial, as you mentioned, there was some evidence that starting early may have a beneficial effect. Leora, what is your approach to Chemo RT and Durva?
Yeah, so we have gone ahead with Chemo RT, and we have started Durva as soon as possible. It's interesting. One of the things that we've encountered, a lot of our patients come from outside of Nashville and 60 miles or more, and the biggest issue has been that the Hope Lodge has been closed, and patients don't have somewhere to stay, and it's a financial toxicity. They're having to stay at hotels. Some of the hotels have been amazing, giving really significant discounts, but it still can cost a patient $1,000 to stay there for a month for concurrent chemo radiation therapy. For Durva, I haven't gone to every 4 weeks. I actually tried it 2 weeks ago, and I was denied by insurance. So we're still trying to work out some of those kinks for our patients. But what we have always done is the patients only see a provider once a month, and they come in for their other Durva visit whenever they want, and they just get labs in the infusion room. So I feel like that's one less touch within the healthcare system that we have to worry about. But I've been prodding ahead again, recognizing we haven't had the surges that Boston had in our COVID-19 cases.
Great. Now, let's say patient has completed Chemo RT and has completed Durva and was on the surveillance phase. This could be locally advanced, or this could be a resected stage 1B, 2, or 1A patient. Has your surveillance of those patients changed, Charu?
Yeah, so we haven't really changed our surveillance drastically. I think, there are certainly patients who have, voiced a fear of having to even go in and get a scan. And I've certainly asked that, can I delay my upcoming 3-monthly scan to 4 months? And in those situations, we have, talked to our patients and sort of evaluated where they are in their surveillance timeline. I've certainly had patients that have delayed their scan by a month or 2, and then I've caught up with them with a telemedicine visit later on. But as a general approach for my patients, I've tried to keep them on track as much as I can. Just recognizing that if there are patients that are earlier on or within that, higher risk period of recurrence, I would like to keep them on a timeline if I can safely do so. And to be honest with you, the radiology staff as well as the radiologists have taken excellent precautions, with thorough wiping between patients as well as staggering appointments, that, it's made it very seamless actually for patients to come in. There's usually no delay in getting their scans, and they've quite enjoyed the experience.
Right. We have also done something similar, which is we have the patients come in, get the scan, but then the physician visit happens by the telehealth platform. So you review the results with them and plan the next one, assuming 3 or 4 months or 6 months down the road, we'll be back to a state where these patients can come in and see their teams in person. Certainly implications in every disease, but none more than stage 4 disease, where patients are having to experience multiple touch points with their team, even on a monthly basis, or if not more frequently. So let's talk about stage 4 non-small cell lung cancer. The exciting news is there are now 7 molecular targets with FDA-approved therapies, and that list is growing. Soon we'll be in double digits, I believe, based on all the exciting new early data that we've seen at ASCO and other recent meetings. So let's talk about targeted therapies for a second. How is your approach to targeted therapies changing? Leora, you do a lot of work with ALK-positive patients and EGFR-positive patients. What approach are you taking for these patients?
So I don't know that we've changed much for that cohort of patients. We have amazing pharmacy support in our clinic. So generally, when we start a patient, the pharmacist counsels them, follows up with them via phone multiple times. And we normally will bring the patients back a couple weeks after they start just for a lab check. To be honest, since osimertinib replaced erlotinib, we've done that. We've been less worried about that because patients always used to underreport their diarrhea and rash, and they'd come in and you'd realize they needed that dose reduction, and we haven't needed that as much. Those patients are still getting scanned every 3 months. It's interesting because for many of our patients, once they walk into the medical center and they realize how sterile everything is, I think we're cleaner and leaner than we've ever been. They're actually fine with getting a CT scan because they get it literally around the corner from where clinic is, come get their labs with us and go, rather than have to get an outside scan. We use Walgreens. We have a partnership with Walgreens for labs. So rather than have to go to Walgreens and for the labs and do telehealth, they're quite happy to just be in and out in within about an hour and have seen us. So for targeted therapy, we're doing fairly similar to what we were doing before.
Certainly. This is the group where we're doing a lot of telehealth, trying to keep those patients away from the center, at least in the acute period. So we talked about oral administered tyrosine kinase inhibitors in this setting. When patients come up with acquired resistance, there is variable threshold to do a biopsy or switch to another targeted agent or another anti-cancer systemic therapy. Is that changing because of COVID? In other words, are you more likely to tolerate some progression in a patient with targeted therapy? And I want to get both your thoughts on this, Charu and Jacob. So Charu, why don't you go first?
Yeah, so I think during the peak of the pandemic, we were discussing these patients in our tumor boards and sort of really getting everyone's opinion because we were carefully balancing the risk of bringing this patient in to do a biopsy. And this was also before we had the universal testing prior to all procedures in place. I feel that now that all patients are getting tested prior to any procedure like bronchoscopy or endoscopy or even an interventional guided biopsy, I feel that our threshold is lower to be able to say yes to biopsies. And we are certainly, for the appropriate patients, taking all precautions to bring them in and do these safely because, they can effectively guide clinical trial enrollment as well as other therapeutic management decisions. So we have certainly tried to increase and ramp up our biopsy procedures quickly and safely.
Great. Jacob, to that point, I've heard some people make the case for liquid biopsies more so than actual tumor biopsies. Is that something that resonates with you?
Yeah, actually, normally that can spare a biopsy. So in someone on targeted therapy and now looking for resistance mutations, if you find that in the blood, then you find it, and I think you can rely on it. If it's not there, I think you still need to do a biopsy. So the right treatment for these patients is still going to be more important than this potential risk for COVID, given that I think in our center and what I'm hearing in all of your centers is that we actually are extremely careful. People find that things are very clean. Everyone's wearing a mask. I certainly feel confident saying that people are safer coming into the hospital for their testing than they are going to the grocery store. So people can come in and get their biopsy, they can come in and get their scan, and they really, I think, are overwhelmingly pretty safe in the institution. And it sounds like that's true of your institutions too. So if we're looking for something and this is going to impact their line of care, whether they're getting a targeted therapy option or chemotherapy, I would still absolutely get the biopsy in the hope that targeted therapy was an option for them, because then that actually is not just a better therapy, and generally speaking, but also less risky during the time of COVID too.
So as you mentioned, pivoting away from targeted therapy to systemic, say, chemotherapy based on what the next appropriate step is for those patients. and then considering those patients along with those others who don't have a target where we're using chemo immunotherapy approaches. I want to discuss that a little bit. How is chemo and immunotherapy used now for stage 4 frontline treatment? We earlier talked about risk factors where immunotherapy was not a risk factor for higher mortality with COVID. But Charu, you do a lot of trials with immunotherapy and chemo and other immunotherapy novel approaches. Your center also does a lot of work on cell-based therapies. So how are you approaching the non-target non-small cell lung cancer patient in the frontline setting?
Yeah, so we had to briefly put our clinical trials accrual on hold. I mean, we were still taking care of our actively enrolled patients who were receiving therapy, but new enrollments had to be put on hold just to make sure that we were safe in our delivery of clinical trials. I think having said that, our preference has always been to enroll patients on frontline clinical trials of novel agents in combination chemoimmunotherapy or just combination immunotherapy. Outside of clinical trials, my approach has been really based on PD-L1 status and really thinking about overall disease burden. I have preferred to use immunotherapy alone for my patients with high PD-L1 expression and use the triplet either through a Keynote 189 or a 407 approach, depending on the histology for anyone that's lower than 50%. And also, considering using the triplet for patients that have a high disease burden or who I, really need a swift response in for patients that have higher than PD-L1 50%. I do think that there are opportunities now with emerging data with both Checkmate 9LA as well as approval of the Checkmate 9LA regimen, as well as updated data from 227 to reconsider these strategies, especially in the era of the pandemic, where we know that chemotherapy may predispose to higher morbidity. So certainly thinking about those scenarios as well.
Interesting you mentioned that these approvals happened in the past 2 or 3 weeks, even while we were in the thick of pandemic. So the combination of EP and Nivo, which is a non-chemotherapy approach, is approved for PD-L1 positive patients greater than 1%. And the 9LA, which is 2 cycles of chemo with EP and Nivo, is approved regardless of PD-L1 expression. Leora, is that something you're thinking about for your patients now, since it has the option of not having to include chemotherapy?
So I guess I'm not as excited as Charu was. For Nivo Ipi, if I'm going to give it, I probably would just do Pembro alone. The greater than 1% to me didn't look that much better than the Keynote 042 data. I think I would have been more excited if the PD-L1 less than 1% got approved with Nivo Ipi, because that actually looked really good for PFS and OS. For the 9LA regimen, we actually had a lot of patients on Checkmate 568, and that allowed, there was a cohort of patients who had the Nivo Ipi. And I will say I was very selective in choosing those patients, and I do worry that 9LA probably had that similar selection bias of, can a patient tolerate this quadruple regimen, similar to giving like carbotaxel, bevatizo, which I've never done either. So, I probably would be quicker to just give chemo and then drop the Pembro than I am to maybe go to that 9LA regimen. But I'm definitely open to being convinced. But that hasn't really changed what I'm doing with my patients right now.
Sure. So we've heard slightly differing views on that particular aspect of IO. Jacob, which end of the spectrum do you fall into?
I'm more like Leora. I think if I were going to give just immunotherapy, I would give Pembro. I don't perceive a dramatic difference between these. And that being said, someone who really has significant bulky disease where they're symptomatic, and I think we really need a response, I would still give them the chemo with it. And certainly now I would. And carboplatin pemetrexed, I think it's pretty well tolerated in general as well. So I mean, just to make the point that there are still patients that do need the chemo. And so even though we might be looking to give immunotherapy if we can, there are still patients that we have to give the chemo with it because they need a response to therapy.
Absolutely. So to counterbalance the two of you, my practice is more along the lines of what Charu mentioned, and you can call it my own bias because of my role in some of these studies of IO-IO combinations. But certainly the points that you all raise are critical as we make decisions. Now, important part of chemo immunotherapy or IO-IO approach is the maintenance part that's continued for, say, 2 years. Especially if patients get chemo plus IO, some people would continue both the chemo part, pemetrexed, and pembrolizumab as maintenance. Some people may feel I can just get away with IO. Is that something that varies because, or have you changed your practice because of COVID? And Charu, I'll come to you for that question.
Yeah, so my practice has always been to continue chemo and so pemetrexed and pembro for my patients that received a Keynote 189 regimen. And that practice didn't really change significantly with the exception of I did consider some patients for a Q4-week regimen of Alimta or pemetrexed, and that was probably the majority of the change that I made to that regimen. I did not get into a situation where I was dropping the pemetrexed solely for the reasons of the pandemic. As we were taking a lot of the other measures to minimize exposure, like doing televisits and minimizing their interaction with healthcare workers. So I do think that those sort of made up for them coming in every 3 or 4 weeks. And I do think that it's important to maintain patients on a regimen that's working well for them. I think we all welcomed the approval of the Q6-week pembrolizumab dose. And I think that for my patients that are on single-agent pembrolizumab, I think has been quite useful. I will also mention that we do have pilot for home infusions, and that's something that we're exploring for patients that are on single agent immunotherapies, for example, to be able to get the infusion at home while we do the televisit.
That's very interesting. I'd be curious to follow up with you in a few months to see how that's coming along. Certainly, I agree with you completely in that the Q6-week pembrolizumab approval is a huge blessing, even if COVID were not an issue, because these treatments are given for 2 years. And for patients to come every 3 weeks once their disease is well controlled or practically gone with these treatments has been an important challenge for certain patients. Jacob, docetaxel, an agent we all love to hate, and it's been around for 20 years. We use it in the salvage therapy setting. How is the salvage therapy for advanced stage lung cancer modified or varied based on COVID pandemic in your practice?
The feelings to docetaxel is really such a good representation of how far we've come in the last 10 years. Because I think docetaxel was commonly something where it was like, hey, this is an option. We really see something from it. And now people are, oncologists are really preferring other options. And I think that just represents that we've had some really well tolerated and effective therapies. And so in most cases in that setting, I prefer to put people on clinical trials. So if someone has already finished chemotherapy, checkpoint inhibitor, and now looking for something, my preference is clinical trials. And we're fortunate that there are a lot of drugs that have been really promising in development as well. So docetaxel is not something I use a lot of. That being said, if I'm reaching for it, that means that there's a real need for it. And I think the balance in all of this is, for every patient, it's risk-benefit balance. And if that's someone where they really need something and there isn't an option, then I would still treat them. And even during COVID, I would do so. But I think you have to acknowledge that in the discussion. And you talk about this is a time of COVID, and my discussion with patients in that setting is really more the importance of isolating themselves than anything. But that ends up being a part of the discussion. So I'd reach for it, but I don't love reaching for it even in normal times, quite honestly.
Thank you, Jacob. As we're talking on the screen, our audience can see some general conclusions from what we've learned in the past few months. from experiences that's published and reported. And some of them include that what we've already known, anticoagulation, patients on steroids have higher risk. We know that prior administration of chemotherapy poses higher risk. Treatments administered to COVID-19 besides chemotherapy are not associated with substantial change in overall outcomes. And the fact that we have to individualize care to patients based on individual patient characteristics. I want to briefly touch on small cell lung cancer before we wrap up. We have had some new treatment paradigm entered the small cell lung cancer treatments. Chemo plus immunotherapy is now used in the frontline setting. Leora, you played a major role in getting atezolizumab plus chemo approved. Is there any difference in how you approach small cell lung cancer, a disease where you absolutely don't want to delay treatment for these patients?
No, for those patients, we've sort of plugged along. I think the only difference, if you're a purist, is that in the Empower 133 trial, atezolizumab was every 3 weeks on a maintenance schedule. And in the Caspian study, which was with durvalumab, the durvalumab was every 4 weeks. And so, but there is now approval for atezolizumab every 4 weeks. So again, when you're talking about minimizing that interaction with the healthcare system, it might have played a role in which regimen you choose up front. But for small cell lung cancer, if we delay until the peak subsides for those patients, the mortality in stage 4 disease can sometimes be 6 weeks. And so there's no time to pause. You just sort of have to plug along and add that growth factor and deliver the care that can potentially prolong survival.
Great. It's very helpful. So we're almost running towards the end of the program. I want to ask each one of you about any specific recommendations or advice you have for our patients and caregivers, starting with you, Charu.
Yeah, so I think as we are re-emerging and re-entering our lives after this and we're past peak, I just share this with my patients on an everyday basis that we must be still very careful and practice social distancing or physical distancing and hand washing, wearing a mask are all very relevant and very important still.
Great. Jacob?
Yeah, the biggest thing I stress to patients is the isolating themselves, washing their hands, being very careful. I think the best thing patients can do to not get COVID is really in their daily lives. The institutions are being very careful and really minimizing risk in the institutions. As I said, I think a patient's risk is lower in our institution than it is at the store. And to remember that family members that are out there getting exposed are going to be exposing the patient at home as well, and that's been an important concept to say to them. The one thing I'll say about just the stress for the institution, I really hope that the remote visit stays. I find that doing video visits with patients is really helpful. Their family members are involved. I can share a screen and show them their scans. There's just so much that we can do, and I think patients by and large have really enjoyed that. So I'm really hopeful that that sticks around as well.
Great. Thank you, Jacob. And Leora?
It's hard to follow those two. I agree with everything that was said. And, I think we need to remember that lung cancer is a pandemic. And it's a pandemic that's ongoing during the pandemic. And patients need to, if they have symptoms, go get seen. We had some near misses at our cancer center with patients with severe complications who almost died. If you're due for your screening, as Jacob mentioned, go get screened because it can save lives. We need to adjust to the new normal, but we need to continue to take care of our patients because the care that we have and the treatments we have, we don't want to lose those survival benefits that we saw in the last few years for our patients.
Absolutely. I think you all made the point that we need to make sure our patients understand the seriousness of what COVID could do to their underlying disease and their overall chances of beating COVID if they were to get it in the context of lung cancer. So making sure they're all taking maximal precautions and practicing physical distancing and other preventive measures are critical. And what I've enjoyed learning just in this session is how we're all evolving, even compared to a few weeks ago to now. Our approaches are being refined, and that's driven by new knowledge that's being generated both in the world of infectious diseases about COVID, in the world of immunology about COVID, and more importantly, work like TerraVault within the cancer community that is helping us learn from experiences of patients that have unfortunately met with COVID so far. I have enjoyed this discussion. This has been very informative. I want to thank all our faculty for spending their valuable time with us today and sharing their insights. I want to thank you, our audience, for joining us. We hope that you take away important points from this discussion and practical knowledge that can help with how you manage patients in your practice. With that, thank you so much. Have a wonderful evening. Bye, everyone.